Good morning, everyone. Are we awake? Did I need to dance more to wake you up, or are we good?
Good morning.
Thank you. Good morning. First of all, welcome to probably one of the most interesting conversations you're going to hear at this event. We're going to talk about public trust and government agencies. Obviously a big deal. As we know, we've seen a lot of loss in trust during the COVID pandemic, but first, let me introduce the esteemed panel here, starting off with Zeke.
I'm Zeke Emanuel, professor and vice provost at the University of Pennsylvania and a venture partner at Oak HCFT.
Leana.
Hi, good morning, everyone. I'm Leana Wen. I'm a physician, public health professor at GW. I'm also a columnist with the Washington Post writing on health policy and public health.
And Amy.
Hi, Amy Abernathy. I'm president of clinical studies platforms at Verily, and I was previously the principal deputy commissioner of the FDA.
So obviously, you probably know these people. They really don't need any introduction, but thank you for that introduction. I'd love to start off with just talking about the most obvious point here, right, which is the COVID pandemic. We saw a huge loss of trust in public health, in government agencies, and I think that there are multiple reasons why, and I know we've all sort of understood the differences. So Zeke, I'd love to start out with you if I could. Tell me what you see as the main cause of that. Is it just that people don't understand science?
No, I don't think it's about understanding science. I think there are multiple causes, but let me highlight a few. The first is, I think you have to see this as a general decline in trust of expertise. And people being suspicious of experts and elites. That's obviously been a theme of Trump and that wing of the Republican Party. And I think that goes a long way to be suspicious of the FDA, the CDC, everybody who's an expert. And I do think that's widespread. Second, obviously, social media means people don't hear the alternative opposing views and can basically hear an echo chamber of their own. And then I do think we have to acknowledge there's been a lot of changing positions and assessments. You know, if you just look at one, the CDC and the WHO on aerosol spread of COVID.
Yep.
Well, if you get something so fundamental wrong and you're resistant to changing it, I do think that erodes public trust. And so I think you have sort of some basic foundational changes. You have a social media environment, and then you have mistakes that we in the field have made that have undermined in real time what the public can trust. So I think all of that combines to decrease public trust, and it therefore is, at least some of it, is not going to be unique to public health. It's wider than public health. It includes all sorts of other institutions.
Right, and we'll get to that with Amy in a second. But Leana, you are a public health expert. You have been in a role in public health and government, and you understand this from a personal level. First of all, do you think there's been a loss in trust? So that's a yes. And then beyond that, do you see sort of a reason why, going off of what Zeke said, there's so many different factors. From the personal side of it, number one, how has that affected you? And number two, do you see the reasons behind that?
Yeah, I mean, I really agree with what Zeke just said, that there is the societal milieu, right, of where we are. And also, I think that there are actually a lot of unforced errors that we in public health made ourselves. And, you know, I think sometimes it's easy to point our fingers at, quote, the other side, right? And say, and it is true, I mean, there are actors out there promoting misinformation, disinformation. Social media platforms have to do a lot better with content moderation, right? Like there are others, and we can say others should do better. But I think we also need to take a hard look at what it is that public health ourselves might have done here too. I mean, I think to Zeke's point, if there's anything that I wish we had done differently from the very beginning, it's emphasizing that change is the bedrock of good public health policy, right? That just like in clinical medicine, if something changes, if the science changes, if circumstances change, you would expect that the recommendations also change. And I think that could have been communicated perhaps even more forcefully from the beginning. I also think that sometimes there is a reliance on the mantra of follow the science, which of course I really agree with. I believe in following science and evidence and research, but science alone doesn't have all the answers. So when you look, for example, last year when CDC changed the recommendations around isolation guidance from 10 days to 5 days and then 5 days with a mask, right? I mean, first of all, it wasn't understood as 5 days with a mask, that second part. It was just understood as 10 days to 5 days. But what was the reason for this? It wasn't because of new science. A lot of the reason was we were facing an imminent collapse of our infrastructure because too many people were out sick at the same time because of Omicron. And I think if the CDC had said, that's the reason, we need people to be able to go back to work, I think that that type of clarity could have actually helped a lot with not eroding trust in our recommendations.
Well, doesn't that go, Amy, we're going to get to you, but doesn't that go to the point that some people feel like they're not really the priority then in that situation? People can say, oh, well, the CDC doesn't care about me, they don't care about my health, they just want to protect, the infrastructure and other people.
I think that they should be upfront with that. Because honestly, at the end of the day, public health is complex, right? There are trade-offs in all of our decisions. A trade-off of lockdowns, shutdowns. You could say, we need this to preserve life. But also there are trade-offs. There are economic consequences. There are isolation consequences, educational consequences. I think it actually would be a lot better if we acknowledged in public health policy that there is a fundamental tension, by definition, between individual liberty and what's better for the health of the public. And the more that we can be upfront that policy is complicated, the more that helps us explain the rationale.
Fair enough. Amy, do you want to respond to that first?
So I agree with what Leana's saying. A couple of additional observations. One of the other things, and it goes along with what Zeke said a few minutes ago, is that as we saw in the pandemic, the story was changing, right? And one of the realities is that this is hard. Understanding how to make sense of the science is hard, and understanding how to communicate it in a way that makes sense to me in my daily life. And so first, the practical reality that I notice that the three of us are doctors, right?
Right.
And when I think about communicating to the patient sitting in front of me, several things. So first of all, I can see that person, understand how he or she is interpreting the information, and not only can I adjust what I'm saying in real time for that person, but also I can cross-check how things are going for that person across time. Whereas in the context of public health communication, we're talking about communicating with the public who's expecting to have a cross-sectional understanding exactly what do I do today, 5 days, 10 days, with a mask, without a mask, right? And where you can't adjust in real time if you need to make adjustments because, for example, what you have advised is impacting their mental health. And so there's a big tension between how we think about communicating health-related issues to individuals to how we think about communicating health issues to the population, and that also that tension of how that can change across time is very difficult. So practically speaking, I'm not surprised we didn't get it perfect.
Can I just pick up on?
Please.
So one thing that I think is really important that both Amy and Leana mentioned is a lot of the public, I think, in this pandemic felt as if the government wasn't taking their situation into account. I don't know how many people here in the audience are parents, but it was clear, you're closing schools, that's, crushing my life, and you don't seem to be taking that into account. And I think if the CDC had had respiratory viral spread, that means it's airborne. That means that the right way to counter it is, we need HEPA filters and good air filtration and masks, and we can keep school open under those conditions. I think parents would have said, wow, they really understand my situation. They're trying to make it as safe as possible in schools, and my kids can continue to go to school, and if I have to work remotely, I can do this, and a lot of the system will go. And I think part of what we saw, and again, this is what Leana and Amy said, and I think it's very, very true, is, people had a sense like those government public health officials were not taking my situation into account, and they did not understand how this one action really just turns my entire life upside down. And that kind of stuff does undermine people's confidence, whereas I think we could have had a situation where we didn't have to close school, certainly for as long as we did.
Well, that was going to be my counterpoint, was there are also people who feel like the government took it a step too far or didn't really consider reality and was basing a lot of it on fear. And I think that still is some of the sentiment, is that there is more fear surrounding the decision rather than actual data, actual science. Anyone have a response to that?
I mean, I would just say that, and I'm going to give a rather contrarian view here, right, about the whole, this is not just about the science and data. I think that there is a fundamental values question too. There are a lot of people right now, so you look at the fact that we're here, right? I mean, most people are unmasked. We're at this conference of more than 10,000 people in Vegas and so forth. And I think a lot of people will say, at this point in the pandemic, with vaccines readily available, with Paxlovid, with other therapies, and also with the fact that COVID is here with us, that we just have to acknowledge that the risk of getting infected is real and it's there, but it's a risk like getting the flu or getting RSV or anything else, any other risk in our lives. I think on the other hand, there are other people who are still choosing to be cautious and are saying there's the potential of long COVID. There's maybe I live with an immunocompromised family member and we want to be still very careful. There are different values here. And a lot of people have said for quite some time that good health is not just the absence of COVID, and we need to contextualize COVID into these other things. So I think it's not just understanding the data to make these decisions. It's also understanding that people have different values. And so at what point do you tip over to say, it's no longer top-down interventions that we need to let people make those individual decisions?
Well, is it in fact that isn't part of it that, we also don't know what the impact of COVID is? Is it actually like RSV and flu?
But I think a lot of people will say, even if it's not, right, that they would make these decisions.
You have a counter?
I'll pass.
Okay. Amy, go ahead.
I was going to say the same thing as Zeke. I'll pass. But I think that one of the issues here is that if you go back to the very beginning of the pandemic and think about what that moment in March 2020 felt like, right? So we were talking about family members dying in the ICU, none of us really being sure what was really going to happen. That was a very different time than we're in now, where we're actually weighing up the risk of COVID and potentially long COVID against all the other risks in our lives. And I mentioned mental health before, but it's really important that it's not just the question of whether or not you might get an infectious disease. It's also the question of what might your fears, values, and the choices you make do to all the other parts of your life, whether that's your health, your mental health, your ability to have work and a productive life in many different ways. And so people are weighing all of those things up now.
Well, I would say COVID is not the last respiratory viral infection we're going to have. At some point, maybe in our lifetimes, there will be another flu eruption that is very serious, and it does seem to me that a lot of these lessons need to be taken by the public health authorities in terms of how to maintain trust and also how to understand, I think, the right response. And one of my fears is in the defensiveness over the mistakes made, they might not internalize and make the appropriate reforms. I think we can develop now, given what we know about COVID and given what we know about how a flu, it's not quite a pandemic, then an eruption that's beyond a sort of annual spread, what the right series of responses would be. Because I think that would go a long way towards assuaging the public's suspicion, at least, and get them to trust the advice.
In part, what we're seeing is, as you mentioned, there are actors out there that are pushing misinformation, and I think people aren't sure how to navigate, in some ways, that information highway nowadays, and there are too many players on either side forcing information forward. I want to bring it to the COVID vaccines, because I think that's one of the best examples, Amy, and this is to you, of how the FDA managed to approve these authorize these vaccines, not approve initially, and get to the point where they were able to step by step get to approval. But then everything that happened in between, the conversations about what booster was necessary, why did we need those boosters? You had people on the advisory committee countering each other on what the requirements were and what was needed. And I think for the first time ever, the public saw that. And I think it's not abnormal when it comes to authorizations and approvals, but for the first time, the public saw that, and that really exacerbated the mistrust. Do you think that's right or wrong?
So I think, so let me sort of take that in a few steps. The first thing is the COVID mRNA vaccine story is a really important story that I think is going to play out more and more going forward. So what we saw was really spectacular discovery, sciences at work, and then these vaccines authorized through EUA on a smaller corpus information. These were shorter clinical trials with fewer numbers of participants, and then vaccines being authorized, and I'll come back to the committee meetings in just a second, and then the expectation that we continued to evaluate those vaccines after authorization and then approval. So what we saw is reliance, for example, on data from the electronic health record systems from Khemlani in Israel. And so in that post-authorization setting, the continued understanding through data and through continued evaluation of duration of effectiveness, safety, for example, your heart or other questions on the safety side. Do you need a booster? Can you mix and match? What about our children? All of these things became critical questions. And so what that story told us was that we could make early regulatory decisions and then continue to cross-check vaccine safety and effectiveness and how to put those vaccines into play across time. And we're still seeing that. That's the first thing. The second thing is, as you pointed out, the public saw the messiness of this. They saw the messiness of interpreting the data in the context of many different populations, interpreting the data with micro evaluations of safety events, and what did that really mean for populations at scale. I remember my mother called me. My mom watched the advisory committee meetings on YouTube, and she calls to say, that I was watching the committee all day. Here's what I want to know, and here's what I'm thinking. And so what you saw was the messiness of that now being interpreted by my mother, who's a very smart woman, but who was now trying to figure out, what does this mean for me? And I think that part of the problem here is that we've shielded the public from that messiness, helped to provide the final action step, and now we're sitting in a place where we're now trying to help the public understand and interpret the messiness in real time, and that's what we saw play out.
Safe to say, without the Super Bowl, that was our Super Bowl to watch, basically.
She watched the whole thing.
I think we all did. I feel like that was the most tuned in public health meeting or a drug approval meeting ever. I want to take it one step further though and talk about what that means going forward, because now we have a population that has been exposed to not just COVID, but also these decisions, and how that plays moving forward, because we also have things like Aduhelm and that drama, that saga, and how that played out. And some of the details that have come out about that, I think, confirm people's suspicion that there's a relationship, as there should be, between a regulatory body and a company, but they misinterpret that or maybe see it as requiring more suspicion than it actually does. Do you think?
I knew we were somehow going to get to Aduhelm.
Sorry.
Zooming out for just a second, as I think about, going from the COVID story to the Anjalee story, practically speaking, there's similarities, right? So what we're talking about is, again, a medical product being approved in this particular setting based on earlier information, a smaller corpus of knowledge than we would usually expect, because in the eyes of public health, there is the observation that Alzheimer's disease is an unmet medical need and therefore is a population of people in need. And so accelerated approval, and then the expectation from an FDA perspective, and also now CMS, of continued evaluation of the medical product post-approval. And I think that that story is going to continue to play out more and more. And we've been seeing this in cancer and rare diseases and HIV for 25 years. Now we're seeing it, certainly in other diseases. So that's the first part. The second part is that FDA, and Janet Woodcock did say this in public statements, had more information than they could, provide to the advisory committee who evaluated aducanumab, or really actually even put in their available info.
And is that normal practice?
Yes, so the FDA always has information from other sponsors, information from the review of other medical products, and is putting what they know about the illness, in this case Alzheimer's disease, the medical product, in this case a monoclonal, and also that potential endpoint in the context of everything else that they knew. The problem becomes, and I think this is where you were really going with this, is that there becomes then almost like a curtain.
Yeah.
And the things that are happening behind the curtain, because some of them can be disclosed and some cannot, for essentially all the reasons that an agency that's responsible for reviewing products that are for commercial organizations has to kind of keep that information appropriately secure, and then has to make a decision that gets communicated, and then gets communicated in a way that the public has to trust, and if you're in a state of mistrust, can blow up in one's face.
So I actually think we've gotten two very important lessons out of the COVID experience and the FDA experience. One is we can move a lot faster than we have done.
Yes.
Part of it is personnel. We need more people to do the work. But there is no reason we have to go back. I think it's in the interest of the American public, it's in the interest of the industry, it's in the interest of the government to have the accelerated reviews that we've had become standard practice. And it's really a resource question. We're not talking about tens of billions of dollars, but we are talking about billions of dollars to the FDA to facilitate that kind of speed in evaluation. It doesn't mean that it's going to be a more cursory evaluation. It just means that the data we've got can be evaluated more quickly because we have the personnel to do it. It doesn't have to, as it were, sit around. The second thing, and I think Amy emphasizes, but I want to make it bold, which is we now need a much better infrastructure for ongoing monitoring in real-world circumstances of the approved drugs and vaccines and biologics and devices that we've hitherto done. The idea that it's go, no go, one decision is ludicrous. We need to have a situation where we can rapidly approve things and get more data accumulation to understand the side effects, to understand its actual potency in the real world circumstance as opposed to the artificial clinical research circumstance. And I think, again, that's an infrastructure we have to build. That's an infrastructure we have to require the companies, whether pharmaceutical or device companies, to actually have in place. My own view is, IQVIA and other companies know how many pills are sold, where they're sold, right? CVS knows every person who's filled. We need to have a way of getting follow-up on those patients in a much more systematic, routinized way. And I think that is an infrastructure we have to invest in, and we have to make companies invest in, because it's so important to know that kind of long-term outcomes and how actually effective the drugs are in the real world with patients who have multiple chronic illnesses as well as whatever the underlying issue is.
So do you hear that, innovators out there? That's a call to action right there.
Yeah, there's got to be a company there, or at least
already
two.
doing it. Well, which brings
Very
me to
important.
the next point, which is transparency is part of the problem, right? That's where people feel like, Amy, you know that there needs to be some level of a curtain, right? And that, I think, is what turns people off. We're so used to having information at our fingertips today that it's like, well, why doesn't the government give us that information? Why can't we be more transparent about the data, about the decision making that went into the changes in the COVID guidance, to your point, Leana? So let me start off with you, Zeke. Do you think that the way the health system functions contributes to that mistrust?
Oh, absolutely. I think, again, I would just sort of differentiate mistrust in public health from mistrust in the healthcare system. Those are two different things. I think a large part of COVID was focused on the public health, but I think mistrust in the healthcare system has been rising also. And part of that, again, is that people as patients are experiencing a system that doesn't seem responsive. It's hard to get your questions answered. It does seem as if, you might be, a hospital might come after you for unpaid bills, that the cost is going up. It's hard to get through to your insurance companies. Get that EOB. I can't figure out why I'm the one who owes $650 on that mRNA. And that does sow public distrust. It also sows a situation where the public, because of the cost, is hesitant about using their services. I'll just give you, I got a bill for an MRI that was either $16,000 or $18,000. Now, that, of course, no insurance company paid that. But just the idea that it would show up on an EOB at some outrageous, $18,000 is roughly a quarter of the average family's income in America. And you're like, for a 30-minute MRI? That makes no sense, and that just undermines the entire trust of the system. And then, the insurance company's paying only a quarter of that, and then I'm stuck with a quarter of what the insurance company isn't paying. It's like a bit absurd, and I think it does undermine, it seems like nothing is real. And that has to undermine public trust in the healthcare system. I'd say the second thing is being able to sort of second guess your doctor by going to Google and search and looking on whether it's Mayo Clinic or WebMD or any of the other sites. I think that also has had a quite undermining effect on trust. Now, obviously, doctors have to give real, live, truthful information, and when they give false information, their patients really should have their trust undermined. But I do think there is a problem here of second guessing, especially given a lot of the, frankly, crap that's on the internet. And I do think that has a sort of negative ongoing feedback loop that's not positive for the trust in the healthcare system.
So can I, pull that forward for just a second, Zeke? And your point was that we need an infrastructure that allows us to continuously evaluate products. But the other part is we need an infrastructure that supports building trust in healthcare, trust in understanding what works for me. And as you pointed out, there's a lot of innovators here in the audience, and thinking about user experience, user design, designing the solutions so that people understand how is this particular treatment or cream going to work in my life? What can I trust about it? How do I make decisions? Leveraging the best of user design to not only build understanding and trust, but also make it so that I have the information that I need for the moment that I need it in my life without the system overburdening me. The fact that people send your EOB on paper is even something that makes me a little crazy. And so I would say that the innovators in the audience think about UX and design as a way of building trust and a way of making sure people know what to do at the right moment in their lives.
The irony, by the way, of that bill is that it's actually supposed to make you feel better that the insurance is covering it, right? Yeah. And it doesn't work that way because people are like, why is it even that high to begin with? Politics. I'll give you a moment. Zeke, firsthand, being on the transition team, talk to me about where you feel politics plays a role in the trust factor.
Well, I think to the extent that we have extremely divisive politics, it undermines public trust because, again, a lot of people think it's to their political advantage to attack experts and attack the experts of the administration and the government. And, one of the consequences, I think, it has been just a huge exodus of people from agencies, whether they're public health agencies, but throughout the government. And that's not good for anyone. We need experienced government civil servants because we have a country of 330 million people and we need to have it run, and the government has a critical role. And if we have a lot of attack on civil servants, some people like Amy have thick skin and can take it. But a lot of people, they didn't sign up for this. They're not going to put up with it. And a lot of people have left as a consequence. And that, on a long-term basis, just is not good. We do need to have turnover in the government. But if you can't attract talented people because they know they're going to have their reputation ripped apart, they're going to have things looked at which are not nefarious and turned into nefarious things, that is going to undermine the efficacy for all of us. And I think using attacks on the government civil servants as a political weapon has been very, very detrimental to the country and the long-term good of the country.
Leana, you've been attacked as well, and you know this firsthand. You've also been a public health commissioner. You know what it's like to be on the inside. Tell me your thoughts.
So prior to COVID, I was the health commissioner in Baltimore, and my biggest concern about what people thought about public health was that they were not thinking about public health, right? That there's a saying that public health saved your life today, you just don't know it. Because by definition, public health works when we are invisible. Well, that was my concern before. I have a very different concern now. My concern now is that the backlash to various COVID restrictions and mitigation measures have bled into so many other aspects of public health. We have seen more than half states pass laws that restrict the authority of local and state public health officials. And so what happens if there's multi-drug resistant tuberculosis or measles, and now we can't do masking and quarantining, and we're seeing childhood immunizations fall off a cliff. And I'm really worried about this. I think we all, if we care about others around us, we should all really worry about this. But I think I'm also, though, a realist and a pragmatist. I hate the fact that public health has become politicized and polarized and inserted in the midst of culture wars because of COVID. But I also recognize that that has happened, right? I wish it didn't happen, but it did happen. And so given that that's the case, that's one of the main reasons why I've been a proponent in this last several months of not leaning into COVID mitigation measures more. We're seeing, for example, that less than 10% of children under the age of 5 have gotten even one dose of their COVID vaccine. I have 2 little kids, 2 and 5. They both got vaccinated as soon as I possibly could. But I don't want for us to be saying, let's mandate COVID vaccines for all young children, because what is that going to do for trust in other vaccinations? I actually think that key to us moving forward out of this is getting away from COVID. I mean, there's so many other public health issues that deserve our attention. Rising cases of overdose, increasing maternal mortality, mental health and isolation. I mean, we can go on for all these other neglected health issues. Those are the issues that have the potential to bring us together and help to overcome, I think, so much of the toxicity that unfortunately have surrounded recent discussions around COVID.
Clearly you're passionate about that, Leana. Amy, having been in the government at the time, seeing the pressure that comes down through various agencies, tell us about that. What is that like?
So, what I was thinking about as you were asking this question is there was this moment where the president was tweeting about the FDA being a turtle. And, there were the turtle tweets, and yet I was looking out at 20,000+ individuals who are working day and night trying to address the pandemic and needing to say, don't pay attention to that. Do your best, just like you've been showing up every day to do. And so my first point is that what is pretty unbelievably amazing is how the people who are in government are absolutely committed to doing their job well and in a way that actually is working for us every day. Politics is only a small part of the government story, and yet it feels like it is the government story. So that's the first thing that was kind of striking to me. The second thing that I'll just say, my public service announcement, is if you ever have the opportunity to serve in the government, do it. It was a spectacular job, and I really can honestly say it is a really important way of both giving back and also getting a lot for yourself. The third thing I would say is that one of the things that I learned while being in government, and this is for the innovators all out there, is the importance of understanding health policy, the importance of understanding how essentially our laws are made and how regulations are made, and actually how to work in a system that, if you don't understand, is going to get away from you. And public-private partnerships, conversations in Washington, understanding how that machinery works should be a part of every innovator's story out there, because I can tell you that that will make your company stronger, it'll make your work easier, and it'll also make public health better.
I have to ask, though, when you saw those tweets, and especially the push for the deadline of the vaccine, how did you feel about that, that someone was basically undermining the work you were doing?
Again, my mother called me, right? So my mom calls, you can kind of imagine that my mom was constantly watching what was going on at the FDA at the time. And she was also my best canary in the coal mine of what was going on. And I felt both sad and annoyed, and then also like, oh yes, don't worry about that, we've got things to do. I think one of the things that I saw when I was in the agency is most people have their eye on where they've got to go and aren't paying that much attention. One of the directors, the director of CDRH, which is the Devices Center at FDA, he once told me that his job in directing the Devices Center was to act as the cushion between Congress and the center, so that nobody who worked in the center actually sort of felt all of the churn that happens at the congressional level. They can do their jobs and keep their eye on the ball.
So can I emphasize just a couple of things that Amy said? And again, I think they're really, really important. One is we have a lifetime civil servants, and they are working in Washington. And one of the things as innovators we need to understand is, they don't have their pulse on what you're doing. They are not out in the marketplace and understanding the kind of problems you're addressing, the innovations you're developing, and how they should think about them. And the second thing is, the way they can get that is by you educating them, but also, when asked, when appropriate, to serve in the government and do the education not in a one-off meeting, but in your contribution to government service, because that does help rejuvenate and educate agencies. And I think that's that kind of ecosystem that we used to have very frequently. We called it a revolving door. I don't think of it as a revolving door. I think it's a way of nourishing and making the agencies aware of what's happening in the real world, but also the real world aware of how the pressures on agencies, the kind of considerations they have to do. It's very important to have that ongoing back and forth, and I think it's essential to having a responsive set of regulations that make your job better.
Fair enough. 2 minutes on the clock here, so I want to get to a solution rather than complaining about the problem. How do we fix the lost trust? Who wants to go first?
So I think that some of the things that we've talked about here foreshadow what I think the fix is going to be. So first of all, we actually have to build solutions that help people understand the information in front of them in ways that are essentially easily accessible and understandable to me. So building in user experience and user design into what we do, making sure that we incorporate in our work experts in communication, in all different kinds of communication, not just, for example, medical experts who are used to talking to individual patients in the clinic. I think these are going to be critical as we think about better communication going forward, and then we got to keep doing the science and getting that right.
I think we should lean into the complexity and the messiness. When I talk to my counterparts in public health around the country, look, everybody, no matter what decision you make, someone is going to say you should have done more, and somebody else will say that you overstepped. And that is just the nature of things, right? Same with the FDA, with decisions that are being made. Somebody's going to say you took too long, somebody else is going to say you should have waited for more data. And I think that is just the nature of it. Leadership means taking a stance, making a decision, and then explaining the trade-offs and how you came up, how you weigh these various trade-offs to get to where you are. I think the better we can do that, the more we're able to restore trust.
So I think there are plenty of things that the agencies need to do in specific, and I think, I would recommend to the CDC that they take very, very seriously, what is the playbook for a response to a respiratory virus that spreads rapidly in the population. But I do think trust in public health, trust in healthcare cannot be separated from the larger social issue. As I mentioned, the undermining of expertise. We have to reinvigorate. Experts actually know something, and we can't just say, they don't know anything when some element of what they've said gets disproven. And the second thing is, we do actually have to do something about the social media environment. It is very unhealthy for the country. And I think those things are true for healthcare. They turn out to be true for climate. They turn out to be true for our politics. And I think we can't separate improving trust in healthcare and public health from these larger social issues because we won't solve the problem unless we get our hands around all of it. That's maybe frustrating to a lot of you. Well, I can't solve that big national problem. Well, we have to be constructive in our voices trying to address these larger national problems. We can't be simply concerned with our own very small sandboxes.
And with that, we are out of time. Please give a huge round of applause to this panel.
Thank you.
Thank you.
Thank you, everyone.
Thanks, guys.